So this time I'm going to present in a slightly different way because I want to get a bit of interaction. It's really difficult when you do a presentation on Zoom. You can't really see anyone, you can't really engage people. So I've chosen to do this next presentation using a different format called Mentimeter. When I put the next presentation up, at the top will be a code. If you go on your phones and just put in menti.com, it'll give you a code to put in and it will link you to this presentation. During it, I'm going to ask some questions, and hopefully, if this works, fingers crossed, you'll be able to put some of your answers on the screen so we can then discuss them as a kind of a live kind of discussion. And hopefully it'll just get you a bit more involved with this conversation, because ultimately this is you guys that will be developing these roles. And it's really about kind of what you guys think is needed and how we can help in terms of developing that, but also from learning from our experience, and also how we kind of move forward from that perspective. So I'm going to just share the screen and then it'll have the code on it, and hopefully you'll be able to kind of follow the information from that perspective. So as you can see, at the top of the screen, I can move that down my way, should be the code at the top, which has a few numbers, which you'll be able to kind of see. So that's hopefully quite good. So if you can just have a little bit of time, kind of do that on your phone, it won't take you very long. And I'll just start the presentation and you guys can hopefully catch up as we're going along. So this is developing the ACP midwife role in triage. And both Ashlea and myself and Abby have talked very much about our experiences with doing this. It's about how you guys who are thinking about developing the ACP role can kind of move forward, and what kind of are kind of nuances in terms of how you would do this kind of to get things going for you guys, really. Let me just, next slide. So that's not the next slide. Someone also once said to me when I was doing my training, just because you can doesn't mean that you should. And I think that is very pertinent to this role, because there's a lot of skills that you can learn. There's a lot of things that you could potentially do. But sometimes within our role, it doesn't mean that we should do that. I think it's something that you should ask yourself all the time, day in, day out, when you're being asked to review patients. Just because you may have the skills to do that, is that within your role and within that expectation of your job role to undertake that? And one of those examples would be, you know, if I was being asked to start night shifts, I would be then expected to cover a more medical kind of background and potentially review patients who would be maybe gynae related and not in the pregnant period. So as a midwife, our NMC covers us with pregnancy and the 28-day postnatal period, but I'm not covered to potentially see people within my role who are not pregnant. I may have the skills to kind of work up a patient in terms of kind of doing the systematic approach. That doesn't mean that maybe I should. I think it's really, really important when you're developing these new roles and advancing practice and taking your practice to the limits, that you ask yourself this over and over again, because I think to keep ourselves safe, to keep litigation safe, I think it's really important to not, we're pushing boundaries, but don't push past those boundaries and don't make your role unsafe. This new role will challenge you intellectually, clinically, emotionally, and developing these role standards, proficiencies, limitations and regulations whilst in training is crucial to ensure the long-term safety of your care provision to your clients. Now, a critical task for health services is to protect those using the service from risk of harm and maintain public confidences in those who are delivering the care. Obviously, regulations of healthcare professionals has an important role to play in this, but however, the growth of these new roles are exponentially kind of being undertaken, and nurses and midwives alike are increasingly taking on more complex, autonomous and expert roles around assessment, diagnosis and treatments. So it's really, really important, until we have that regulation with the NMC, that we are safeguarding our own practice when you're developing these roles. So it's really important to have those thought processes before you even start. So I thought I'd just bring up the 4 principles of medical ethics. Now, I am by no way means a legal expert, but it's really, really important to kind of remember when you're undertaking your role and developing these roles, that you remember the 4 medical ethics, you know, the autonomy, respect of patients' right for self-determinations, beneficence, our duty to do good and not potentially do non-maleficence, and the duty to not do bad. We never ever go out intentionally going out to harm patients, but potentially we could do non-maleficence because we're not trained in a specific kind of role. So it's really, really important that you kind of undertake these 4 medical ethics when you are looking at your role specifics, your proficiencies, and kind of what your limitations are and when you would refer on. So that's just kind of really important to kind of have a think about when you are writing these job descriptions, writing your proficiencies and starting that kind of job training, is to understand how important it is to work within your limits and your NMC kind of roles and expectations. So I'm hoping this works, but I just want to ask you guys what you would consider to be the important building blocks to developing any new role. So I'm hoping that your responses will come on screen, and then we can kind of work through them a little bit in terms of what you guys think are the building blocks for developing this. Oh, it's working. So excited. Amazing. Some really good answers coming on screen. You guys could just do my presentation for me. You've answered all my questions for me. So yeah, we've got stakeholder engagement with service-driven, have a good foundation of understanding, patient care. Governance keeps coming up over and over again, which is great. MDT support, absolutely. I think you guys, I mean, listening to the other guys speaking this morning, I think it's kind of been evident that you have to have those clear boundaries of what is expected and what the doctors expect of you and what your midwife colleagues expect of you. I think that's such a good starting point to have those boundaries set out when you're starting this role. That stakeholder engagement, whether it be obstetrics or your HOMs and your DOMs, getting that engagement from the very onset, because you really don't want to be starting this kind of journey, developing yourself and developing what potential care you can give when there's no outcome of this job that comes from that. So I think it's really good to kind of make sure that you have that kind of engagement with them from the onset. Support, definitely, and that's just not from the obstetric people who are kind of supervising you, but support from the shop floor. Explain what the role is from the very onset. People won't know what an ACP is or what it will do. They'll be a bit fearful of it. They'll be a bit kind of worried whether it's going to take over their job roles. So that explanation and talking about it, getting that chat going on, is so important. Yeah, and having that defined scope of practice. I think we talk about not working outside of our scope of practice. And I think this is where like the job descriptions really kind of help us in terms of keeping ourselves in line, but also supporting ourselves and providing a little bit of kind of governance behind what we do in case we, start to kind of sway out of those lines. So some fantastic answers here, and I think, yeah, you guys have really got those kind of building blocks that will kind of set you forward for the next kind of obviously future ACPs. So really, really, really good. Next one. So kind of my building blocks would be starting from that job description. When I did my training, the very, very first task we had to do was write a job description as a trainee ACP. And what that would look like in terms of what things would change as we become qualified, what things would stay in terms of governance, supervision, what would that look like? And then looking at your job specifics, what you would be doing during your training and what would be expected of you when you had qualified. And when I first took this on, I think, oh, it's just a job description. Oh, God, come on, this is such... I just want to get on. I want to do physical tasks. These patients. I want to see these patients. I want to save the day. I don't want to do a job description. But actually, it's been the backbone of moving this ACP role forward and given us that ability to work within that the role and the expectations and keeping us within that, because if we don't have that backbone of the job description, you may be expected or maybe asked to do things that you don't feel comfortable to do. And that job description is there not just to safeguard yourself, but it's there to safeguard the trust and the patients, most importantly. So it's an official written document that describes the role, the responsibilities, the duties, and qualifications of any particular job in healthcare. It is so important that we have it, that we know about what's in our current job descriptions, and how that will benefit us in terms of what is expected of us in practice, but what the trust will cover us when we are practicing with our patients. And don't forget that kind of the trust's main role is to ensure that we protect those who are using that service. So these job descriptions are there not to just protect us, but to protect our patients. Very quick, just a fun kind of question that doesn't really matter whatever answers you put. Who could confidently tell me what is in your current job description, roles, responsibilities, and trust expectations? So some of the questions on here is, I 100% know my job description and my trust standards, 100% know it. I have a good understanding, but not 100%. I probably have read it, probably when I got my first job role. So just kind of see where people lie in terms of what they know about their current job descriptions. Hopefully this will work, fingers crossed. Oh, this is so exciting seeing it moving. Yeah, so I think there's kind of a vast amount of you on here that kind of are happy with your job description, know what your roles and expectations are. There's some that have got a good understanding, but there's quite a lot of you also, and I probably am with them until I wrote my recent job description. I'd probably only read my job description when I first got my job role and hadn't really revisited it. And I think it's something that when you are moving into this new role, it's certainly something that you become more aware about, and it's more important to be more involved with, especially as your role expands and you develop more clinical skills, that is interpreted within your job description, so that actually you know that you are covered in terms of what you should or shouldn't be doing within your kind of job role when you're developing these roles. So that's really good. So the reason why we go on about job descriptions and working within that capacity with what's in that is because your trust will have some vicarious liability behind that. They, broadly speaking, as an employer, is liable for employees' negligent actions and if committed in the course of the scope of the employer's employment. So which is really closely connected with what the employer is authorised to do by the employer. So that's why it's so important to know your job description, know what's in it, and know what your limitations are. Ultimately, most job descriptions are very generic, but when we're writing these new roles, it's really important from the onset, because we are pushing a few boundaries. We want to make sure those boundaries don't blur. We don't want to blur any lines. We want to make sure we are very clear in what we are expected to do and what we are happy to undertake. And that's why we have the opportunity to get involved with the writing of these job descriptions to make sure that actually, you feel confident, the trust is happy, and therefore it's really important to think about these aspects when you're developing these roles. All staff expected to work within the organisations which enables us to deliver safe care and appropriate care in accordance with the regulatory and professional standards. So we have a duty of care to be able to provide this expected work kind of ethic. Staff should provide reasonable standards of care to patients and act in ways to protect their safety. Now that is from a legal kind of document. And it says we should be able to provide reasonable standards. It never says high standards or low standards, always reasonable standards, because that's how you're measured. So it's just important to kind of, when you're wording these documents, that you do kind of seek advice in terms of what the trust advice is in terms of writing these documents to get it right for you. Because ultimately what we don't want to do is put ourselves or the patients at any risk or harm. So, setting clinical practice standards for training. As you've heard from Alicia, myself, that training can be very different from different universities, but ultimately in clinical practice, depending on your area, the standards for the training should be very, very similar. I think when developing any new role, it's important to take time to consider what clinical skills will fundamentally be required to allow you to expand your scope of practice, and also the advance your clinical practice yourself. How are these standards going to be assessed in training, and what are the qualifications that you need, if you need any at all within that training perspective, or is it just is clinical assessments enough, or do you need any further qualifications for that? Think about also who ideally supervises you when you're training, and then also beyond. So these are the questions you need to be asking yourself. Who is going to be my supervisor during the training process? And actually, is that same supervisor the right person to continue that, or do I need other people? I know that sometimes, I think my other colleague that I was talking to the other day, when they did their training and they have their supervision, they utilize other ACPs in the trust that are very widely utilized in terms of if they had a cardiac patient that they've seen in terms of their maternity review, that they have done a supervisory with a cardiology ACP specialist to kind of go through that element of that practice to make sure there was nothing they need to learn from that kind of exam. So it's utilizing other supervisory aspects and other ACPs or specialist people in your area to make sure that your practice remains at the best standard it could possibly be. So it's about kind of reaching out to other areas in your trust to find out what ACPs are in other areas and what they can do for you to improve your own care. It's so important to get those reach out points, because they ultimately are your reach out points when you're in clinical practice as well. It's obviously very important to take that integrated multi-professional approach with the training and development. It's not just about midwifery. Like I say, you'll get a lot more experience going out of the field a little bit during your training to get that experience, like you say, seeing more medical problems and being exposed to that in the ED departments or in the medical areas, kind of the rapid access clinics in the main hospital. And you can see how the ACPs kind of work through those kind of medical conditions that are outside of pregnancy, which then you can utilize those skills back in maternity, kind of when you're actually starting your roll up. So it's about looking at what those clinical practice standards are and how you're going to develop them when you are starting your own training. So thinking about all the previous presentations that's happened today, and hearing about the clinical skills that myself and Alicia have, Ashlea, has gone through, what do you think should be set as a triage ACP standards as like a standard practice? What skills do you think should be required? No responses. Please work. Don't know. I don't know why it's not working, but I can't. Oh, we've got 4 responses coming through. Yeah. Yeah, brilliant. So these are some of the things that you may want to consider when you are looking at developing your own skills or that skill set. And certainly we'll be taking these answers. I'm doing a bit of work with the NMC in terms of looking at these set standards. So it's certainly be something that we could take from here to them, looking at kind of what their set standards would be. So yeah, we've got critical thinking. Yes, definitely. Clinical assessments for sure. History taking, appropriate training, prescribing, growth scans. Yeah, so very much, you know, all the things that we were talking about earlier, but with a lot more kind of information on here. So really good answers coming through. I really think, you know, having reviews of the systems, prescribing comes up a lot. I think within the ACP training, that is one of the courses that you'll do standard, because it's one of the courses that will kind of, it's a linchpin to how you are reviewing patients. So yes, that's a definite kind of skill set that you're going to need. So some really, really excellent answers that I'm going to take from here and take all your kind of answers and take that to our next forum with the NMC, and looking at these set triage standards, because I think it's really important that we set something that we are working towards, so that makes, when you are developing these roles and you're going through the courses, you know, ultimately when you're in triage, you've got to hit, I don't know, your prescribing, you've got to hit your speculums under 37 weeks, you've got to hit your diagnosis, your assessments, maybe particularly HDU training, and you need to be able to show and demonstrate those set skills to be then happy to work in triage or as an ACP as a standard training practice. So really, really good ideas here. And like I say, we'll take these on and kind of go from there. So brilliant, brilliant answers. Excellent. So like I was saying, there's some upcoming work with the NMC, and I'm sure they'll be more than happy to kind of have more people involved in this. But it's about setting those standards for training, looking at what is the essential standards for an ACP and midwife, ACP midwife. What are the essential standards, and then looking at more specific roles, so triage roles, maybe postnatal roles, labour ward roles, and looking at what those specific standards look like for each of those roles in those areas, with an underlying essential basic standards that everyone needs to meet. Ultimately, my skills in triage will be very, very different to someone who's on delivery suite. But the essential underlying features of being able to clinically assess a patient from top to toe will remain the same. Our prescribing practices will remain the same. So there are very, generalistic standards that we need to meet, but then with the added specific triage area or delivery suite area or postnatal area standards that would be required from that perspective. So that's kind of the upcoming work, which is exciting, because I really feel that the ACP role has been recognised on a national level, that it's been recognised as a really good format of care, but we need that regulation, and this is going to be the next step on to hopefully formalise this role and pushing us forward, with the support of trusts, knowing that there's good regulation behind the actual kind of development of the role, which is really good. I think all this stems to, you know, this good input, this thought process of that development, the JDs, the different kind of clinical skills and technical skills that you've got to be kind of hitting when you're in the areas. Because what we don't want to do is blur the role. And I know Abby talked about it kind of in her presentation earlier, and it's important to understand your trainee role limitations and your end goal of what you want to get at the end of your role. And this is to consider roles such as kind of the ACP or the physician associate, and how potentially those roles could look very, very blurred. It's important to ensure the roles remain midwifery focused, you know, and look to be that maxi midwife and not that mini doctor. we can do so much in the ACP role that keeps normality there for the patient, that keeps their needs high. And I think that's really, really important to maintain that and maximise the midwifery output, rather than that becoming that mini doctor and just doing those doctor reviews, which, you know, is just not within the role. There are grey areas. It's not all black and white, and we know that very, very clearly, because scopes of practice can expand, but it's about how do we try and keep things more clear. The British Medical Association versus the General Medical Council at the moment, there are regulations, they're kind of bringing up some legal issues regarding the danger of blurring lines, and for patients it's important that they understand the roles. There's a big case going on between the two of them at the moment about a patient who was seen by a physician's associate on a number of occasions and hadn't really understood that there wasn't a medical person seeing them. They hadn't been seen by a doctor. They didn't really understand the actual role. So it's really important that when you are introducing yourself as a trainee or as an ACP, that you try and explain that role to that patient, that you are a midwife and you are not a doctor, but you are trained to undertake these reviews and then refer on. It's about making sure that public that understands your role and their expectations of that role for them. Everyone, like I say, everyone has a right to know who the healthcare professional is and what they are qualified to do, and more crucially, what they are not able to do. So it's really, really important that you don't blur those lines, even though how difficult it can be, that you just, and no matter how hard it can be, that you work within your role and work within that job description to not just safeguard yourself, but safeguard your patients. How would you look to ensure the ACP role does not blur these fragile lines, and is this even possible? I may have answered a little bit of those questions, but it's just nice to kind of maybe see what you guys think that you are going to do when you're developing these roles. Oh, there's such a delay. Oh, they're coming in. Yep. So definitely having clear guidance, good communication, yeah, job descriptions, saying no. And it's such a difficult little word to say, because we're all very keen just to kind of say yes and just, you know, be the yes, I'll do that person. But I think it's really, really important that you have those clear boundaries, know your clear role responsibilities, and when it doesn't feel right, say no. Just because you can doesn't mean that you should. Yep, focus, job descriptions. Good. I'm liking hearing that there's lots of job descriptions coming up, and I've shared my job description with one of the people who are organising this day. So she should be able to share it out with you, so you could use it as a guide. Like I say, it's not 100%. It's not, you know, probably there's things that we can probably improve on it, but it's certainly safeguarding what I'm doing currently. So do please utilise that as your base to start from, and kind of utilise that for yourself. Yeah, not afraid to escalate. I think that's really, really important, that just because you're the ACP in the area doesn't mean that you know everything. And I think people seeing you escalating kind of gives them assurances that it's okay to do it for themselves as well. So yeah, and I think that's really important to know your own limitations. So some really, really good ideas in terms of how you're going to ensure that your roles do not blur those fragile lines. I think that's really, really good that you guys have got a good understanding of that. So that's really, really, really good. Brilliant. Some really good responses. Funding. So you've got the job description, you've got on the course, you've got the supervision, the mentorship, you've got your set standards, you've got your specific qualified things that you need to get qualified for. And then there's funding, and it all comes down to money. And I think it's important to ensure whether you either on the apprenticeship route or the MSc or the main MSc route, that you work out who funds you once qualified. Start that conversation from the beginning. It's, you know, like I say, get that engagement from your management in terms of your training and development of these roles, because I think it's so important, and it's soul destroying when you're going through the 3 years working so incredibly hard and there's no role at the end of it. You can see the benefits. You're dying to show people the benefits, but you can't get that last post because there's no funding for it. So start those conversations before you even get on that kind of long road, because it is worth it, but it's the heartache. We're trying to avoid you having the heartache. So it's having those conversations, because we know the roles are beneficial. There's so much research out there that shows them that patients have good experience, they have good outcomes from having an ACP care for them. We need to prove that in maternity and ensure that we get the funding for this really, really good potential role to kind of keep that kind of momentum going. So definitely have a chat. There's no right or wrong way for funding. There's no has to come from midwifery budget, has to come from the obstetric budget. There's no right or wrong. It's just ideally the midwifery budget would be perfect, but it's kind of whoever's going to fund it if there's an opportunity to do that. So generate those conversations from the very, very start. And like I say, you've got the supervision, so develop that structure that encompasses regular supervisory reviews. Obviously, I have mine every 6 weeks with my consultant, and every 6 months to every year with my consultant midwives. And if I've done anything particular that's in terms of more medicalized reviews that I feel would benefit from a cardiology ACP review, just to make sure that actually they're happy with kind of what I was doing and go through that with them as a supervisory, then I've got opportunities to do that in my trust, because we have the ACPs already in post in a variety of different areas. So like I say, find out who your ACPs are, find out who your contacts are, because you can utilize those within your supervisories to kind of help build your own kind of education and understanding, but also build your care that you're giving to your patients. Practice reviews with the clinical supervisor is a key element of the ACP role. Oh, I spelled that wrong, do apologise. Ensure the continuation of self-review reflections, because I think it's really important to self-review what you're doing. That also keeps you in a line in terms of looking at re-reviewing your job description. What are you doing within that? Have you gone above your scope because you've kind of maybe done some more training? Do you need to put new things into your job description to keep yourself covered in terms of what you're doing? This all comes in within that supervision. Development of skills required practically. We know that our knowledge expands as you know, every day our knowledge is expanding, and sometimes our expansion of skills that are required also needs to expand. So it's about that development and how we're going to keep developing those skills when you are in training. So yeah, so that's kind of, it's really, really paramount to make sure that we are observing what we're doing, making sure we're maintaining our skills, maintaining our standards, and working within our kind of role and expectations. And it's really important, because we are particularly entering this new role, that we are safeguarding ourselves, but the role itself to kind of continue the development of it. That's the end of that presentation. And I think if you've got any other questions, we'll take them now. I think Ashley's going to kind of jump on with me to see if there's any other questions that you might have. So yeah, hopefully you enjoyed that little bit of presenting in a different format, and I loved all the answers that you gave. I think it's going to be such a useful tool for us to kind of stream some of those questions and answers when we're working with the NMC. So thank you very much for answering those.
Thank you, Sam. I did really enjoy that. I thought it worked really well, and it was so nice to see all the responses coming in really quickly. I was typing in some responses and people were typing in faster than I was, so that was good.
It was just nice to know there's other people out there, because you can't see anyone.
Yes. We don't have any specific questions at the moment. I actually did think of a question whilst you were presenting, and now it's completely gone out of my head. I don't know whether there was anything else that either of you two wanted to comment on.
I think for me, like Sam said about the funding, is a big thing that kind of I'm going through now with sorting my role out. So I have worked as a trainee from September in a band 7 role, and then the plan always has been, in my mind and in I think everyone's mind, that we have in our triage, we have 2 midwives. We have a band 7 midwife and a band 6 midwife, and we've just introduced a telephone triage midwife. But the plan for in our unit was always that I would be in addition to that team, to have the time to review the patients and to be available across the unit as well if needed. But having met with my head of midwifery about a few weeks ago to discuss it, they've basically said that there's no funding. So they looked at short-term medical funding, whether because that we have all of these unfilled triage gaps on the rota, but that wasn't possible. So the plan is to replace the band 7 with myself in triage, in which you're then expected to be the midwife in triage and the ACP in triage, and try to be doing 2 jobs at once, which I know, having worked in triage as a band 7, won't work. You don't have enough time to do your own job, let alone doing that and the role of the ACP. The head of midwifery is quite confident that in probably 9 months' time that will be changed, because they're redoing the birth rate plus, which she's assured me, will then incorporate having a 6, a 7 and an 8A in triage. But I think it's not ideal because it's started. I think as soon as you start something, then people aren't bothered about changing it, and they don't see how it's working. Whereas I think ideally, if we'd have been able to have these conversations, and I think it's just been very slowly, it's been massively on my agenda, but not as much on anybody else's. There's only so much you can bug people. So I think that it would have been ideal if this birth rate had been done previously, and that there was a job funded and ready to go into. And I know that the trainee ACP, who is at my trust, who's just finishing her first year, was also hoping just to step into my training role for her then now subsequent next 2 years. But again, it's the communication and funding, and there's lots of issues. So I think funding is one of the biggest barriers that we're facing.
Yeah, I would agree. I think as well, there's the equality across professions as well, because obviously ACP roles are so well established in nursing. I mean, if you go into any emergency department in the UK, you will meet a nurse practitioner. If you go into any GP surgery, you will meet a nurse practitioner. It's well understood, it's well funded, and I think because we just haven't had them, to kind of get that across is quite hard to the senior teams.
Yeah.
And I think it will come with time, because it has to, in order for there to be equality between nurses and midwives, that needs to come. But yeah, it is definitely a battle, especially with the current situation of finances in the NHS. Yeah. There's one comment on here. So Fiona has said, I am strategically leading on the development of ACP roles in midwifery in Northwest London. Any advice for me?
I think probably like you, I think Ashlea was saying, looking at the funding opportunities before, I think that needs to be probably one of the first questions in terms of how you're going to fund this role. Looking at, I think strategically, which areas you need the ACP in, and looking at what the fundamental things that they can do for that trust. What are your problematic areas in terms of patient review, patient guidance? Triage seems to be a big thing at the moment in terms of what's in the national news. So that's, is a natural thing for us to progress into. But there may be other areas that need, ACP being developed. So it's looking at kind of what the role can do for each area, and then kind of planning whether the ACP could ultimately kind of slip into those roles as well. But yeah, definitely funding, knowledge of their role, and setting out kind of training packages for them if that's not what's set out from the university. I think probably the starting point.
Perfect. So we don't have any other questions.